Hi, my name is Stan.
My name is Connie.
My name is Judy.
My name is Alien, and I'm a caregiver to my mother.
And I care for my mother, Octavia.
And I'm a caregiver for my mother.
And I'm a caregiver to my husband, Art.
I'm a caregiver for my wife, Ann, who's 72 years old.
Basically, I've done everything for providing for both of them.
I take care of my mother on the weekends. I take her grocery shopping.
Not only household chores.
I provide her medical care, coordination, driving, errands.
Choosing meals, making meals, cleaning up.
I find that I take care of anything that he can't take care of.
Sometimes I find balancing time a real challenge.
The difficult part for me is taking me into consideration.
Balancing her needs with the needs of my family, the needs of my marriage, and my own needs.
Staying calm, nice, and positive.
The real challenge is, of course, the distance and the moment you get that last phone call.
What I love most about taking care of her is knowing that we're providing a secure and comfortable home for her.
It's the time we spend together.
Is the adventure of finding out new things all the time to trying to help him stay out of pain.
My name is Ed. I'm a spouse and I'm a caregiver.
My name is Colette. I'm a daughter and a caregiver.
I'm a caregiver, and I'm a daughter.
And I'm a wife and a caregiver.
I'm a daughter and a caregiver.
I'm a son, a nephew, and a caregiver.
Hi, my name is Deborah Day, and I help manage United Way Caregivers Coalition. While caring for a loved one has its special rewards, it's a very challenging job. It can be stressful, overwhelming, and sometimes lonely. Each caregiving situation is unique, but all caregivers share the need for information and support. And that's where the Caregivers Coalition comes in. We help caregivers receive the support they need to take care of their loved ones and to take care of themselves. Caregivers who lead healthy, productive lives will be better caregivers. The most important thing to remember is that as a caregiver, you're not alone.
So I am a geriatrician. If you don't know me, that means I have special training in taking care of older adults. So there's a natural tendency towards developing skills and an interest in taking care of individuals with Alzheimer's and related dementias. So that's what we're going to refer to, Alzheimer's and related dementias. So I thought what I would do, let me see, there we go. This is what we're going to talk about. And if there's just too much information, we could scroll through the slides. There are a lot of slides. It's a lot of information. So if you have a pressing question, then you could stop, and we'll see how much we can get through of this evening. But we're going to talk about the different types of dementias, and I get that question frequently. My mother has Alzheimer's, or, what's the difference between dementia and Alzheimer's? And I'll explain that to you. There's hundreds of different types of dementias. There's common types, which we'll talk about this evening, but there's hundreds of types of dementias. Then we'll talk about, that's Alzheimer's disease and related dementias. That's what ADRD is. We'll talk about medications that are available, maybe a little bit about some of the clinical trials. There, in the next probably 5 years, there will be hopefully some breakthroughs on treatment. And we'll talk a little bit about prevention, because there's tons of literature out now. That's a very hot topic, prevention for Alzheimer's disease. And then managing challenging behaviors. How do you assess them? How do you approach the individual that has these challenging behaviors? And then if we have some time, we could talk about transitioning to palliative focused comfort care, hospice care. So I'm board certified in internal medicine, geriatrics, and hospice and palliative medicine. So I do continue to take care of my patients if they transition to hospice care, even though I'm not a hospice medical director per se anymore, but I do manage their care. Okay, so let's talk about a population that is aging in the world. In this country, we're really, really getting very, very old. And you could actually, is there a pointer? Oh, there is. That's exciting. A lot of people have seen slides like this. By 2050, the percentage of individuals over age 65, over 20%. So we're kind of flat here. But you can see how much that's increased over the years. And this is called the squaring of the population. So these are people over 85 up here. And then by 2050, see how it's squaring out here? We used to have more people down here, right? And now our population is starting to square out like that. So look at all the individuals that we have over age 85 in this country. I love this slide. This is by Rosalind Carter. She says there are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. I respect all of you for coming because I can't imagine how difficult it must be if you're a caregiver to come out and find somebody to stay with your loved one that you're taking care of. So let's talk first about the different types of dementias. So dementia is a umbrella term that describes a lot of different types of dementias. Like if somebody says, I have cancer, you say, what kind of cancer? And the same thing should be for dementias. So as we learn more and we're studying more and more information is coming out about treatment and disease, the pathology behind them, then we could better describe what type of dementia the person has. And right now, unfortunately, it doesn't make that much of a difference because we don't have that many different treatments for each type of dementia, but it will definitely make a difference. And then we'll distinguish between, does this patient have a dementia or do they have what's called mild cognitive impairment, which is going to be really, really important as well. So Alzheimer's, Lewy, these are the top 3 type of dementias: Alzheimer's disease, Lewy body dementia, vascular dementia. They used to call that multi-infarct. They pretty much call it vascular. There's a couple of different types of vascular dementia too. Mixed type is actually really common as you get older. So it's very rare to have somebody that's, say, 88 years old that just has pure Alzheimer's. They often have Alzheimer's plus vascular disease of the brain. Frontotemporal dementia, and there's different types of FTD, and then Parkinson's disease dementia, and then there are a whole host of others and subclasses. This is a busy slide, but it's meant to be that way. This is a classic slide. It's old, but it really hasn't changed much. In the middle here is Alzheimer's, and it's between 60 and 65% of people that are demented have Alzheimer's disease. And then to the right, you could see it's the Parkinson's disease type dementias, Lewy body, Parkinson's disease dementia, variants, and then there could be a mix of Alzheimer's plus Lewy body dementia. On the left are the vascular type dementias. You see you get this mixed type, which is actually really common. Alzheimer's and vascular, they have common pathology and disease processes behind the two. So it's common to see vascular and Alzheimer's, or commonly, and sadly I see this a lot, people have Alzheimer's and they have a big stroke. And then you see a tremendous decline, like Mrs. H. And then there's different types of vascular dementias depending on where the strokes are in the brain. This class is almost like a separate area. Other dementias, frontal lobe or frontotemporal dementia, is probably more common than and see, I see a lot of this, and a lot of doctors never see it, but it's because of the population that I treat. I have quite a few patients with frontotemporal lobe dementia, which has its own characteristic presentation, and which I'll get into. And then the other less common, Creutzfeldt-Jakob, is what they call prion disease, that mad cow. Cortical basilar dementia, a degeneration, kind of looks like Parkinson's disease, or progressive supranuclear palsy, which actually Dudley Moore, the comedian, died of that. And then there's tons of others. So it gives you an idea of the spectrum of the diseases, that not all dementia is Alzheimer's. So this is busy too, but I just want to point out this area of study is really very hot right now. So MCI is actually cognitive impairment, but not yet dementia. So I'll explain what I mean in a second. There's different self-reported memory complaint, mild forgetfulness. There's actually a continuum where people will say, oh, I don't know where I put my keys, that type of thing. Mild forgetfulness, changes that are normal changes with the aging brain, then age-associated cognitive decline, then cognitive impairment not demented, meaning that you are impaired perhaps memory-wise or other maybe complex tasks like balancing your checkbook, but you still can actually remain independent. Then you have MCI, you don't have dementia yet, and then transition to MCI, and then a transition, which I'll show you, into a dementing illness. This is not meant to, you don't have to take notes, although there will be a quiz afterwards, but seriously. So you'll sound really smart, if you go to your doctor with your loved one, you say like, well, does my mother have MCI or does she have Alzheimer's? Yeah, dementia. Amnestic MCI, we used to call this amnestic MCI. We know actually most of the time it's prodromal Alzheimer's. So now we can make a diagnosis of Alzheimer's disease without the dementia. And this is the area that's very important because that's where the treatments will start being effective. A lot of the clinical trials that we used weren't effective because they were used too late in the disease, or they were used in people that didn't actually have Alzheimer's because we didn't have the right diagnostic tools yet to diagnose actually Alzheimer's disease. There's this section here, multiple domain. Now, how do we find this stuff? You have to have something called a neuropsychological evaluation, which is very important when we talk about diagnostic testing. Everyone that has a cognitive impairment, most everyone, if they're more advanced, they may not need it, but a neuropsychological evaluation gives a lot of information, like what do they have, what's going to be the disease progression. Non-amnestic mild cognitive impairment is commonly more vascular disease. But amnestic MCI is important because it most likely says that you're going to develop Alzheimer's dementia. So that's where, and there's a lot of interesting research going on about MCI right now. This is a complicated slide because we actually don't really know what starts Alzheimer's disease. We really don't know. What we see in the brain now with the end result here, these are abnormal proteins called amyloid beta and then tau, this other protein, and then you basically get cellular death and you get all these development of gunky proteins around the neurons and gunky proteins in the neurons, and then the cells die, and that's how you develop a dementia. But all this action up here is where we really need to work, and because there are some controllable things to prevent dementia, actually, which I'll talk about a little bit, but that could be the whole hour of the talk. But it's complicated, and we don't actually know what starts this whole, there are risk factors, but we really don't know what starts this whole cascade of events that causes Alzheimer's. So I just put this up here in case anyone has a real interest, in those that particularly have family histories of Alzheimer's. You may be interested in looking up all of these different programs and diets. There's some literature out lately. This is called MEND, Metabolic Enhancement for Neurodegenerative Disease. It's actually been pretty well studied for people with vascular and Alzheimer's disease. And they've shown actually in early disease you could reverse some of the cognitive impairment. And it really focuses around exercise, diet, primarily a Mediterranean diet, keeping your brain active, sleeping well, stress management, active social life, and all of these things. Doctors don't have any of these, so we're all going to get demented because none of us get it. I was just saying, I was on call last night. Stressful lifestyle, don't get a lot of sleep. You can't really exercise regularly because we're working so hard. But anyway, I try really hard. But this MEND, you could look it up. It's out of UCLA. If you have an interest, there's another program called MIND. This is a busy slide, but this talks about all of the, and this will be available if you want to look at it, all of the different things prevention-wise. Optimize diet, minimize simple carbs. Sugar's the killer. Fat's really not so bad. It's sugar is the killer, they found, right? Sugar's the killer. Reduce stress, optimize sleep, brain stimulation, cognitive training, all of these things. This is about prevention. And once we identify people with MCI, then trying to implement this type of stuff and have people lose weight and start getting active. And it does include some supplements as well. is really kind of the hot thing right now. Okay, so moving forward, I just wanted to show you a picture of this because everything, all the symptoms that people have that are related to their dementia have a reason. They're like there's a physiology and there's a chemistry behind it, depending on where it happens in the brain. So if you have a stroke, or you have frontotemporal dementia, that's a better example. In this area, the frontal lobe will planning and also the logic and basically able to filter out, not to say things that you shouldn't say out loud. That's the frontal lobe. People that have frontotemporal dementia develop symptoms based on damage in this area. And Alzheimer's starts pretty much like in this area, the hypothalamus, which is the memory center. Most of these progressive neurodegenerative diseases, though, they start in an area, but then they actually spread through the whole brain. So eventually, people end up with a lot of other symptoms, not just in the area that the disease started in. So I just want to show you that, to show you that there really is chemistry behind all the stuff I'm telling you about. Okay, so let's start with Alzheimer's. This is just some factual information. I mean, financially and emotionally, it takes an incredible toll on our country. And the vast majority of people that actually are caregivers are unpaid, not skilled caregivers. You learn like a parent, you learn in the shop. You learn what to do. And you hope that you find a care team that's going to assist you along your journey. There's the population as we grow older, there's a lot more dementia, but actually the past few years there's actually been less prevalence, and we are living longer and healthier with better quality of life. So that actually there's a trend going that is a good thing, but we are really getting old, and up to 50% of people over 85 have some type of cognitive impairment. This is shocking, right? Every 68 seconds someone will develop Alzheimer's. It's the top 6 cause of death in our country, and it's the only one without a cure or treatment. There's no treatment, really, which is amazing, right? So, if you have coronary disease, we keep people alive a long time with stents and bypass, and not even bypass so much, heart transplants. It's the top 6 cause of death, but it's the only condition that there's no care, no treatment or cure for. So that's pretty significant. They've been working on it a long time too. It's so disappointing when I talk about this because I never really have good information. I don't have anything that seems particularly hopeful. It's coming. Not yet. It's coming. So risk factors are pretty much the same. Age is the #1 risk factor for development of Alzheimer's and other types of dementias, except for frontotemporal dementia, which is found more in people in their 50s and 60s, although you can get people older developing that condition too. Family history, certain genes, actually there's increased risk. This ApoE4 is a significant risk, which we don't screen for that, by the way. Medicare doesn't pay for that. You have to enter a clinical trial for us to actually check your ApoE4. And we'll talk about some diagnostic testing that's really in the pipeline to help us have better diagnostic tools for diagnosing dementias. High blood, these are all risk factors that you can have an impact on. And they have, just like a risk factor, everyone knows high blood pressure, diabetes, high cholesterol, increase your risk for stroke. It increases your risk for Alzheimer's as well. So if you take care of all this stuff, then you could really decrease your likelihood of developing Alzheimer's. Excuse me. Smoking is killer. And smoking is bad for not just your lungs and your heart, but it's bad for your brain as well. These are the positive things that can have an impact, which we talked a little about, mind and mend. Head trauma as well. So they actually looked at people who've had head injuries, and there's more after the injury, and they do an autopsy, there's more of those plaques and tangles. It's an inflammatory condition, and by the time people develop the symptoms for Alzheimer's, they've had it for 10 or 20 years already. So that's what I mean. We need to find out who's at risk and who are we going to screen and how can we get to these individuals before they actually develop the dementia itself, because by then we really don't have much. The diagnosis is a very thorough history, and oftentimes not just examining the individual, but their caregivers or family members to get a really good, reliable history. Sometimes the history is not very reliable if you ask an individual. Symptoms and progression. Alzheimer's disease is a progressive condition. So if you have some memory loss and 3 years later it's the same, you don't have Alzheimer's. I mean, there's a book out that's calling Alzheimer's a spectrum of illness, kind of like autism is. It definitely is, because it's probably more than one disease. We don't really know what it is exactly. We know the outcome, but we really don't know what starts the disease process. So there's probably more than one disease process going on in the brain. So some people may have a more slower course, and some people are very rapidly progressive, but everyone progresses. That's part of the diagnosis. Risk factors, medication review. I love to deprescribe. That's the catchphrase right now. Is deprescribe, take drugs away. I do a lot of that. Yeah, so take a lot of drugs away. A lot of over-the-counter drugs that are very dangerous for older adults that nobody would know. And people come in and they tell me they're taking Tylenol PM, and I'm like, oh my God, my hair is on fire. That diphenhydramine, and there's a whole long list if you really are interested. It's called the Beers criteria, just like the beverage. And there's a whole long list of do not use drugs in older adults. So look at their medications. Laboratory testing. It's incredible how many people I see that have low B12 levels that are never ever looked at. Never. It's actually pretty amazing. And that has a significant impact on cognition and also mood. So it's associated with depression as well. Brain imaging, that also amazes me. People that are diagnosed with dementia, even started on treatment, never had an MRI or a CAT scan. And make sure they don't have another condition like normal pressure hydrocephalus or how many strokes they've had, or I've seen people with brain tumors that are misdiagnosed. And then the neuropsychological evaluation, which is really important. It's about a 2-hour testing period. It's done usually by a PhD neuropsychologist. And there's a whole bunch they look at all different types of cognitive domains, not just memory, but visual, spatial, and complex executive function, things like that. And then it comes into a certain profile, which really gives you a good picture. What kind of dementia does this patient have? So just from what the physician does in the office, you often can't tell, what kind of dementia does this patient have, or are they MCI, or are they on the fence here, quite transition dementia. A neuropsychological evaluation really, I think is a very important tool. And there are some, depending on the group or whatever neuropsychologists use, they do use certain other modalities to manage MCI, like cognitive rehab, electrical stimulation of the brain. There's a lot of things actually that are interesting out there that are available. And the neuropsychologist that works, well, he actually is moving right now, so it's a little bit tough, but I've worked with him for about almost 15 years, and he does all those type of kind of, not mainstream modalities that I think may be useful, including talk about diet, supplements, etc. This is the Diagnostic and Statistical Manual. This is a psychiatric criteria. Some people do call it a psychiatric illness. So you have to have memory impairment, one or more of the following. Aphasia is difficulty naming things. Apraxia is like, you don't know what to do with the pencil. I'm not going to go into details too much, but anyway, you do have to have these characteristics, and then a significant impairment in social or occupational function, and represent a decline from your baseline. So you have to know what the person's baseline is. And then the onset is gradual. So if this happens in 6 months, the person was functional, independent, working and driving, and now they're demented, they don't have Alzheimer's. They have something else. The pathology, we talked a little about these aggregates of these things called amyloid plaques that are outside the neurons, and then inside the neuron is these neurofibrillary tangles that are this abnormal tau protein. So there are it's an inflammatory process, and there's a lot of oxidative stress, and prevention focuses on like an anti-inflammatory diet and things like that to prevent progression. This is a little bit of a schematic, and so I just put this up here because where we are with treatment is here. It's really sad. We're here. we're here trying to replace the chemicals that are not sufficient in the brain because the cells are dying. And really what we need to do is shift up here. We actually are, there are some things in the pipeline, beta secretase inhibitors, to prevent this. This is amyloid precursor protein to break down to this abnormal one. This protein is sticky and not soluble. It stays in the brain. We have amyloid all over, but what happens normally is it gets metabolized and it comes out of the brain. Your body metabolizes it out of the brain, but if it's not metabolized normally by these abnormal enzymes, then you get this sticky stuff and then you end up with the cells dying. So really what we need to do is go way back up here. We're getting there. Okay, next we'll talk about vascular dementia. Everyone okay here? Okay. So it used to be called multi-infarct dementia, presumed to be multiple areas of cerebrovascular disease. Most people that have vascular dementia, even if they don't actually have a motor deficit or a part, their arm is weak or their speech is slurred or something, they usually have a stepwise deterioration because they have, an infarct. Basically, like you have a heart attack and part of your heart dies. Same thing happens with a stroke, that you have part of your brain dies. So depending on where those brain cells are damaged will give you the symptoms. And if it's deep in the brain, where it's not unlike an area of the motor, then you may not have any motor symptoms. You may not have weakness or slurred speech or anything. You just may have memory loss. These are some of the risk factors, and you see how the same they are, right, as Alzheimer's. Isn't that interesting? Except for AFib. So people, that's why now you see all these Xarelto and Eliquis commercials out there. We anticoagulate almost everybody, unless they have absolute contraindication not to anticoagulate. And there's no age limit. I have people in their late 90s, 100-year-olds on anticoagulation to prevent a stroke due to AFib. There are 3 different types of strokes. Isn't that interesting? The thrombotic stroke is probably the most common. That means that a plaque sticks in the vessel, and then, like a cholesterol plaque or a plaque may rupture. Just like you have a heart attack, you have a stroke. And this blocks off the blood supply to that area of the brain, and that part of the brain dies. An embolic stroke is like what you may have with AFib, where a clot develops in your heart and gets shot off up into and blocks a vessel. And a hemorrhagic stroke is where you have a bleed. So it's this weakness in the vessel wall and an aneurysm, and you have a bleed. So they're all called strokes, but they're just different reasons why you have them. So everyone knows Dick Clark. He had a big stroke. Still worked on rocking New Year's Eve, though. God bless him. He had a big ischemic or thrombotic stroke, and there are different areas of the brain. So as I pointed out, I think I may have mentioned the cortical is the big thinking area of the brain, and you can get any of these: ischemic, embolic, or hemorrhagic. Subcortical is deep in the brain matter. Other terms are called lacunar infarcts. And then there's another type of dementia we call Binswanger's, which is usually lots in the deep white matter of the brain, tons of strokes there. And there's some characteristic features of individuals with Binswanger's. It's a type of vascular dementia. It's probably more common than people think. So this is what I was talking about. This is busy, but it tells you, see, number 4, this is the area of speech. So if you have a stroke here, then you may lose your speech, or you may lose understanding of speech. You may be able to speak, but you don't know what you're saying. You don't understand what people are saying. And the same thing, depending on where the stroke is in the brain, you can have a brainstem stroke, and then you're in trouble because that's the area that's responsible for your breathing and what your heart does and things like that. So anywhere along here, depending on where you have the stroke, tells you usually what kind of symptoms a person will have. Subcortical is in the deep white matter of the brain, and these are what we call lacunar infarcts commonly. They're usually from high blood pressure, high cholesterol, deep in the brain matter. Those are subcortical. Sorry, there's a typo there. Subcortical structures. This is a picture of a big cortical stroke. That's common, actually, a middle cerebral artery stroke. That's what Dick Clark had. Usually facial droop, slurring, and one side is paralyzed. That's a classic, that's what it looks like on an MRI. And these are lacunar, this actually are probably embolic strokes. See all these little dots. We see that not uncommonly with people with F.A.C.P that are not treated. Get the showering of all these emboli all over the brain, all these little tiny dots here. That's bad. And then a subcortical stroke is deep in the brain matter. These things are ventricles. That's where your spinal fluid sits. These little white dots here, that's a subcortical stroke. And you can have problem here. You can have motor problems, weakness, etc., where they could be very silent. Now I tell somebody you've had like 4 lacunar infarcts. They're like, what? I had a stroke? Because it's silent, but it may not be silent for cognition. Lewy body dementia. That's what Robin Williams had. They found that on autopsy, and this is maybe the second most common type of dementia. Depends on who's diagnosing and things. But it's probably up to 25% of people have Lewy body dementia, and I'll describe what that means in a bit. These are some of the symptoms. Visual hallucinations are very common. Well-formed visual hallucinations, very, very common in Lewy body dementia. That's like the characteristic feature of it. In early disease, only about 1/3 of people have hallucinations. Anybody know anyone with Lewy body disease? Oh, yeah. It's a tough disease. It's got a lot of behavioral stuff. So there's memory problem, fluctuating levels of attention. So somebody could be really spot on and good, and then they're really, very, very impaired. They fall a lot. They may faint. They have trouble with sleep disturbances. REM sleep disturbances where you act out your dreams. It's a very, very hard disease. They look like they have Parkinson's, but they don't. This is a complicated slide, but it helps to distinguish, like, how do you have Lewy body versus Parkinson's versus dementia? It's not always clear. Earlier in the disease, it's probably more easy to make the diagnosis, but a good clinician often will be able to tell you. Lewy body, later in the disease process, may look a little more like Alzheimer's, early in the disease, or it may look more like Parkinson's earlier in the disease, and people misdiagnose it. They have some characteristic features, the two of them, that people are stiff, they are often shuffling. Lewy body, people don't tremor. That rolling that people have with Parkinson's, they usually don't have that. But they're both very sensitive to medications that you may use for hallucinations. So you have to be really, really careful. You don't give drugs like Haldol or Risperidone to people with Lewy body or Parkinson's because you take away their mobility, even if they are having hallucinations. Once again, this is an abnormal deposition of protein in nerve cells, and they have a characteristic appearance on autopsy or under the microscope. They're called Lewy bodies. More in men. As I said, it might be the second common cause of dementia. The difference between Lewy body too is these type of Lewy bodies and abnormalities. It's all over the brain in Lewy body. In Parkinson's, it really starts just in the deeper areas of movement, which I'll show you in a second. Frontotemporal dementia is some people. Anyone know anyone with FTD? No. Yes. Yeah. That's a tough disease. It often presents in a younger person, and it presents with a lot of behavioral stuff, like bizarre, disinhibited, strange stuff. There's a couple different types of FTD. The behavior variant is the one where, when I was practicing Manhattan, there was an OB that carved his initials in a woman's abdomen after a C-section. And he had FTD, like that bizarre, weird stuff. It affects memory, language, emotion. These are the areas that I said, they manage, people will become sexually disinhibited or very oral, eat a lot. And there's probably more of that out there than people think. It's just, once again, it depends on who's making the diagnosis. There's a couple different types. The behavior variant we talked about, and language variant, which this is pretty. Well, I actually have about 3 people in my practice with primary progressive aphasia. They haven't had a stroke, but they can't speak. And that's part of a different type of dementia, FTD. Basically, I'll move forward. And then there's variants of FTD. So there's cortical basal. There's really a lot of different types. So a good neurologist that focuses on dementia, because a lot of neurologists don't do good dementia care. It's just not their area of interest. may be able to diagnose some of these things, but I rely mostly on my neuropsychologist for that. Parkinson's disease dementia, how do you tell the difference between Parkinson's disease and Lewy body? Is people with Parkinson's have the disease for a long time before they develop dementia. So they're not going to present with that shuffling gait and hallucinations, and a lot of behavioral stuff, and memory loss, and you say they have Parkinson's dementia. They get the Parkinson's, and then years later they'll get the dementia. And it's about a third, you could see 10 to 30% develop over 10 to 12 years, and up to 80% by 20 years of having the disease. So although it starts in the movement area of the brain, once again, it's a neurodegenerative disease that spreads throughout the brain. And that's what he had, pugilistic Parkinson's, from being beaten in the head so many times. It starts in these areas of movement control. And basically, eventually the cells die. They stop making this chemical called dopamine. And initially we give people dopamine, and then eventually, as the disease and the neurons die, then that stops becoming effective too. It's a very difficult disease. And the other dementias, which I pointed out, normal pressure hydrocephalus is where there's too much fluid in those ventricles in the middle of the brain. Alcohol, HIV, MS, and traumatic brain injury. There's a bunch of others, as I said, too. Okay, so how do we treat this stuff? So we can talk about medications first. I'll tell you what's out there now. So this has been out there a long time. Donepezil, that's galantamine. Donepezil has been out probably about 25 years. It used to be called ACETYLCHOLINE. And it's approved for Alzheimer's disease in all stages, mild to severe. And people ask me, when do you stop the drugs? I stop them when they don't work anymore, when the patients become so functionally impaired that the drugs really aren't supporting anything. If the memory's gone, but they're still feeding themselves, I don't stop the drugs. I mean, I think that's what we have. There's nothing magical about them. They're only effective significantly, like 20-25% of people you'll see a robust response. But as long as you tolerate them, we continue them. Galantamine, this donepezil, galantamine, and rivastigmine are called cholinesterase inhibitors, and they help to elevate the acetylcholine in the brain. They actually prevent breakdown where it acts in the neuron, so they have more of that chemical around the brain that helps in things like memory and other cognitive things. Memantine, or Namenda, is the newest thing on the market. It's been out for a while as well. It works differently. I don't know if I have a slide on it. No. Some people think it actually has a protective effect on, it's hard to explain. It works on a different chemical in the brain. It works totally different than the other. So they do have a combo, this NAMZARIC, that's brand. It's a combination of memantine and donepezil. So it's common for people with Alzheimer's disease to actually put on both. Memantine is really for moderate to severe disease, so we do hold it until people develop moderate disease, so we got something for them. And most of these drugs really aren't used in mild cognitive impairment. There are some doctors that use it, but there's not tons of literature support that really does anything with MCI as far as preventing transition. But if you're on ACETYLCHOLINE and you reach moderate, then you can put somebody on NAMZARIC, which is a combination, one tablet. They all have side effects, and we deal with them. There's nothing approved for vascular dementia. Maybe galantamine is a little bit more effective than ACETYLCHOLINE. Basically, it's all about modifying the factors so that we can prevent more strokes from happening. Lewy body, once again, there's nothing approved. We treat Lewy body primarily with drugs like donepezil or rivastigmine or Exelon patch. I don't use the pill; it's just toxic on your GI tract. We use the same type of drugs that we do for Alzheimer's for all the dementias because there's nothing else. Sometimes people that are really, really stiff and have difficulty with their mobility, you can try dopamine medicines that we use for Parkinson's, but you have to be cautious because it could worsen the hallucinations. So you have to be really cautious when you use stuff like that. And then we'll talk about the neuropsychiatric stuff, the behavioral stuff. You have to really, really be careful with the drugs that you choose because you could make a lot of their mobility symptoms worse. I mean, you could take somebody that was walking with a walker and having difficulty swallowing, and now they're totally frozen, if you use the wrong drugs, if somebody has Lewy body dementia. Parkinson's disease dementia, we use the usual Parkinson's, the dopamine drugs like carbidopa, levodopa, and other dopamine agonists. Cholinesterase inhibitors, which you talked about, we use the same, Aricept, Exelon, Razidine. And then there's also tends to be a lot of neuropsychiatric symptoms with Parkinson's disease as well, which I'll talk about. And once again, cautious use of antipsychotics, which are drugs like risperidone and Zyprexa, and I'm sure everyone's familiar with these. Usually, yeah. So you treat your usual Parkinson's, and then you want to add a cognitive enhancer, generally. And there are some people that aren't on cognitive enhancers. They don't tolerate them, or they choose not to use them. And believe me, there's nothing magical about them. This is a new drug. Anyone ever heard of that? Nuplazid. Yeah? So it's the only drug that's FDA approved to treat the psychotic symptoms with Parkinson's disease, because it doesn't work. All the antipsychotics block this drug right here. Right, and that's the basis of the disease. So, oh my God, you give somebody an anti-dopamine drug and they have Parkinson's. This drug does not do that. It's really expensive, but the company helps you. It's like thousands of dollars. The company will help you. I've used it once, not particularly too successfully. Yeah. So, what usually brings people into my office is this stuff. What we call neuropsychiatric symptoms. Another term is called the behavioral and psychological symptoms of dementia, or neuropsychiatric symptoms, behavioral symptoms, whatever you want to call them. And they come in clusters: aggression, apathy, depression, psychosis, agitation, and all of the diseases that I talked about have these. And they vary, depending on the condition. We could talk a little about each individual one. Which one do you think is most common? Across the board, mild to severe in any dementia. Which one is the most common symptom? No. No? Nope, it's apathy. It may not be the most troublesome, but it's the most common. And actually, it is pretty troublesome. It's often misrepresented as depression. They'll say, oh, she's so depressed. Not depressed, apathetic. That part of the brain that engages us socially doesn't work anymore. It's very hard to treat. And by the way, there are no drugs, none, well, except for the Nuplazid, to treat any of the neuropsychiatric symptoms in dementia. Nothing FDA approved. Nothing. Yeah, wow, right? So everything I use is off-label, so nobody sue me. I'm completely out there. Disclose there's no drugs that are FDA approved for the behavioral symptoms, except for depression. Huh? Well, there are like consensus guidelines and experts that come together and say this works for that, and it's first do no harm. I mean, we'll talk about environmental management. That's the first thing you try to do is manage the environment around the person that has the problem. If you need to use drugs, then there are certain drugs that are better than others. And some of them are not really responsive to drugs either, which you all know that, right here? Yeah. But you guys do a great job. I mean, you have to be creative. Okay. So just briefly, I'll get this quickly. So these are the chemicals in the brain that are affected by dementia. And it depends on, as I said, it depends on where the problem in the brain is and what's affected. In the earlier stages, as I said, acetylcholine is more effective in Alzheimer's, but eventually the disease spreads through the brain. And then all of these other things, serotonin, this is a happy chemical. GABA is like an inhibitory type chemical. Dopamine is for movement. I'll actually have a few slides on these. Glutamate actually is the chemical, the excitable, activating chemical that Namenda works on. Norepinephrine is like activating, energized chemical. And there's a lot of other ones, but these are. So there is science behind what we choose and what drug, at least what I choose, what drug you choose to treat the symptoms that people are having. I talked about acetylcholine, starts here and then spreads, these tracks spread through the brain. If you don't have enough of it, you have poor memory. That's the basis, they think, of delirium. When people come in the hospital, they have a urinary tract infection or they get the wrong drug and they're really, crazy delirium, either flat and withdrawn and confused, or they're agitated and, hallucinating and pulling their IVs out. If it's too much of it, then too much floating around, then people are agitated. Dopamine, as I said, A decreased function is characterized by Parkinson's or Lewy body dementia. People are kind of flat, you know, that flat, masked shuffling, not enough dopamine. Too much make people psychotic. And so that's why those antipsychotics block dopamine, most of them. Serotonin is, see, this is the serotonin, the pursuit of happiness. That's the serotonin. That's what everyone needs, their serotonin elevated. This is a happy chemical. And this is why we use drugs like, they're called serotonin, selective serotonin reuptake inhibitors. They raise serotonin in the brain for people that are depressed, but too much of it is not good either. You have to have just the right balance. And the same thing we talked about, norepinephrine. GABA is an inhibitory, too much GABA, people are very anxious as well. And then, and then glutamate is what we talked about. Using Namenda too early alters this metabolism in the brain, so, you know, it's for learning and things like that. So you really shouldn't use this too early in diseases. In fact, I take it away a lot because people aren't really ready for their Namenda yet. Okay, so we manage like you asked, so what do you do about it? Well, we do use drugs, and there are things that we use, and you have to thoughtfully use them and take drugs away, and it may not work for this person, it may work better for this person. I started using something in my practice about 4 years ago called pharmacogenetic testing, where, and Medicare, pays for it. You take a cheek swab and you send off the person's DNA, and it tells me how you metabolize these drugs, which is great, because, you know, if I give you 5 milligrams of Lexapro for your anxiety and then you're a zombie, it means you're probably not metabolizing it. It stays around a long time, may not be the right fit for you. And that's the future of medicine, is really tailoring your medications to your DNA. So I use it all the time. It's great. Patients love it. They're like, wow, that is so cool. Really, usually it tells me what I already know. You know, I see the person's clinical response to the medication, and then the DNA profile kind of supports what I usually know. So the antipsychotics, these are common ones, that risperidone, this, you may know them generically, quetiapine, aripiprazole, blah, 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 whatever. Antipsychotics, mood stabilizers, Depakote is commonly one that I use a lot of it. For pure agitation, it has less side effects than antipsychotics. For people that are just irritable, agitated, without psychotic features, I use lots of Depakote. It's commonly started being used for people with bipolar disease as a mood stabilizer. Occasionally Lamictal. I don't use a lot of Lamictal. There's not as much research around that. These are seizure drugs, actually, anti-seizure meds. And then the laundry list of all these antidepressants, and there's a whole bunch of new ones. Antidepressants include selective serotonin reuptake inhibitors, so they raise serotonin, and then serotonin and norepinephrine reuptake inhibitors. So the norepinephrine up there too. So people that are really flat and withdrawn, I may use an SNRI because it's more activating. And then I try that for apathy, because apathy is a tough one. Sometimes stimulants, or sometimes, you know, those that raise the norepinephrine in the brain to wake people up so that they just don't sit there all day. And then benzos, we use them cautiously because they have a lot of side effects in older adults. You know, Ativan, Xanax, Valium, forget it. It's got a half-life like a week. So if you give somebody a dose of Valium, it sits in their system for a long time, and then it's metabolized to an active drug that can cause falls and worsen confusion. You give somebody, and it happens commonly in the hospital, people are very delirious, agitated, pulling, and they get a dose of Ativan, and then they're slogged. And then they wake up more confused and agitated, this like paradoxical reaction. So I use these, but you have to use them cautiously. Nuedexta is my superstar. It's about 80% effective for challenging behaviors, right? I have quite a few people here on Nuedexta, right? Right? She's a supporter. It's about 80% effective, I think, which you never hear with a drug. It's not approved yet. It's off-label. It's actually approved for what's called pseudobulbar affect. So you might have seen the commercial with, what's his name? Where he's crying. What's his name? The black actor. He's crying and then laughing, where people can't control. Yeah. Danny Glover. Yeah. That's Nuedexta he's advertising. And they're actually trying to get it approved for behavioral problems with people with dementia. It's in clinical trials right now because there's nothing. But when it works, it really works. You know, people that actually you cannot manage them, or they have a lot of intolerable side effects to drugs, then I use Dexa. We sample it a lot. It's very expensive. It's actually a strange combination of dextromethorphan, which is in cold cough medicine, right, and quinidine, right, which was used for arrhythmias or like quinine-like drug. So people are like, well, you know, maybe I can get like tonic water and mix it with some Robitussin DM. No, it doesn't work that way. And the way it works actually is the quinidine, it's a tiny dose. It helps the dextromethorphan get into the brain. And it's supposed to help normalize the neurochemicals. It really works. It's a great drug. I use quite a bit of it. Okay, so that's about the drugs. And as I said, I mean, it depends on the individual, and you really have to see people frequently and have good communication with the caregivers, et cetera, to pick the right drugs. So BPSD, we talked about these clusters. The ones that probably get people placed, you know, in nursing facilities are like the agitation, things like those that are not amenable to treatment. Things like wandering is also a really scary thing, and actually doesn't respond to any drug unless you sedate the person to, you know, that they won't move. So these are the areas. Okay, so the problem with these, I mean, as you know, it's terrible for the, not just for the caregiver, it's terrible for the person having them. I mean, imagine that, you know, a person that's agitated and can't sit, and where am I going, and where am I going to go, and you know, that's horrible. I mean, so we don't just treat that because it's difficult for the caregivers and the caregivers get burnt out, but it's horrible for the individual that experiences them. Also decreases their ability to think clearly, and you know, their whatever cognition they have, you want to maintain that to manage this kind of stuff. Exposure to dangerous activity. I actually had a patient. They found her, fortunately. She lives in South Orange. This was last week, and her daughter called and said that we can't find mom. She was getting ready to transition her into a more structured care environment. Lived in South Orange. Got on the train. And the guy in Starbucks gave her the money because she went to Starbucks every day. She said, I need money. I need to go to New York. They found her in Brooklyn. Yeah, she's fine. But they found her in Brooklyn. When I practiced in Manhattan, I had a patient that went from Manhattan across the Brooklyn Bridge. So it's pretty scary. So that dangerous activity, wandering, eating unedible things, eating dangerous things. I had a patient who they found in the kitchen with the cabinets open, with the rat poison open. These things usually are not amenable to medications. So as much as I'd like to help you with the wandering behavior, I can't medicate usually. We try to get people to sleep better, but it's usually changing the environment around the person. That's what this section is about. Wandering is a tough one. Vocally disruptive, calling out, screaming, you know, those type of things usually don't respond to medication unless you sedate the heck out of somebody. Nobody wants to do that, right? I had a gentleman here who did this. He used to go in the, remember him? He moved elsewhere. He used to pee in the corners. You guys were so creative. They'd put him in a onesie so he couldn't, right. So trying to, I have a patient right now who actually has a vaginal condition where she itches. During the day, she's fine. At night, oh my God, she scratches herself raw. So we're trying to come up with ways that we could change the environment around her husband so she doesn't injure herself. Hiding and hoarding, that is like a very basic primitive reflex that we have that comes from the primitive brain. So when the dementia, you know, it gets advanced enough that it gets rid of the big thinking part of the brain that's so damaged, then we have our primitive brain. So we used to hoard, right? We used to be hoarders because we didn't know when our next meal was, right? So that's what they're hoarding. Hiding and hoarding things, and a lot of those that, and also the behavior that you have where you won't let your spouse out of your daughter, you know, you're attached to them like glue. That they're afraid of separation anxiety. So a lot of the very primitive things that we had in the primitive brain are still there. So a lot of these behaviors are based in the primitive brain because we don't have that big cortex anymore that filters things and help us to think clearly. And that's what we call, they're called environment bound. So you'll see people are very, very dependent on what's happening around them. You know, if there's a lot of activity, like holidays are tough. There's a lot of activities and a lot of sensory input, people get very agitated. So because they absorb, you know, they become their environment. Same thing if somebody is like, you know, not a lot of stimulation is no good either. They sit flat and don't know what, that type of thing. Taking their clothes off. So you have to focus. All of these things don't respond to medications very well. So that's where, you basically count people. This delirium thing is really important. Is the patient delirious? And that's why it's important that what the baseline functional status is, because oftentimes they come in the hospital and they say, oh, the patient has moderate to severe Alzheimer's, and the person is unresponsive. That's not normal in their stage of dementia. Their baseline function was walking with a walker. They fed themselves. A patient comes in, you have to evaluate, do they have a delirium? What's going on? They have an infection? Did somebody, give them medications they shouldn't take? Something else going on? They have pain. What's triggering the behavior? And that's the other thing as caregivers, if you can, to try to identify what triggers that behavior. And last year we got a grant, my neuropsychologist and I, to run this thing called the Caregiver Boot Camp, where he and his behaviorist taught people how to collect data to identify what triggered it, by what time of day, what was the intensity, how long did it last. Try to identify what the unwanted behavior was and try to focus around changing the environment around that. Like, for example, people that don't want to be bathed. That's a really common thing, right? So sometimes what you need to do is, and I'll actually show you a technique too. Maybe it's too early in the day. Maybe it's too late in the day. Maybe they don't like they don't associate well with the individual that's actually doing the activity with them. So you have to try to figure it out. Or maybe it's too cold for them. You have to try to figure out what that individual needs. Sometimes it could be something as simple as they're thirsty, they're hungry, they need to go to the bathroom. So you try to identify as best you can. You can't always. I try to get that out of caregivers. What do you think? What was happening when they do this? Let's see if we can get to the reason without medicating again. I'm working with a family right now, a 96-year-old fellow who has live-in caregivers and everything. Every morning at 5:30 he gets up screaming, help, 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 and we cannot figure out what it is. And I've tried a myriad of medications and distraction and techniques, and we're still working on it. And it's very, very distressing. It's distressing for him too. Like, why is he screaming help? Like, what is going on? You try to figure it out. Just remember this. It's easier to change the environment than it is the patient. Always. Always, always, always. These are some theories, unmet needs, meaning that we don't know why they do it, but there's a meaning behind it. If somebody's saying, I want to go home, 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 what are they looking for? People that actually looking around, well, there's a reason behind what they're doing. You may not always know, but you try to identify that so that you can address that with changing the environment, educating caregivers, or etc., instead of just pulling out the drugs. Always remember who the person is. If you have somebody that was a night owl, worked the night shift, they're not going to adjust to your structure of going to sleep, lights out at 10 and up at 7. That's not going to happen. And you try to actually force somebody to succumb to your structure, then you're going to get pushback. So you have to always remember who the individual was before they had the disease. I love this. It says, please breathe. Pain. Why is the individual having this? Are they in pain? Are they bored? Do they have to go to the bathroom? Simple things like this that people don't think of. And I really try to get family members and caregivers to think, what could it be without writing a prescription for risperidone. These ABCs of behavior are approaches. These are cognitive behavioral approaches. What identify the stimuli, what's the behavior, and then what's the reaction. And that is, I'm sorry, I don't know your name. This lady here was telling me that she trains caregivers. This, you kind of go along this, like how do you react to that behavior? And a lot of what they do, cognitive behavioral stuff, is kind of what you do with the toddler. You don't want them to do that, so you don't punish them, but you may not give them cheer for it, right? You want to support the things you want them to do and not support the things that are unwanted behavior. So it's a similar thing, actually, for a lot of these behaviors with people with dementias. Patient-centered always. I'm going to go through this slide, but anyway. So the basic stuff is identify if there's a medical problem. Some people, if they're waking up screaming in the middle of the night or they can't sleep in the middle of the night, maybe they're in heart failure. Maybe they can't breathe because they're lying flat. Or it could be any number of things. Treat what underlying, you have to be really detective. Correct sensory deficits, people that are hearing impaired and visually impaired have much clearly, right? Worse cognitive impairment. Turn the light, I see this all the time. I go into the hospital room at 10 o'clock and the lights are out and the patient's in bed. It drives me crazy still. Reorient people. It's daytime, put the lights on. It's nighttime, put the lights off. Quiet time, things like that. Regular structure. Structure is very important for people with dementia, and that's why you see, like, if you take mom, it goes from one sister for 3 months to another one. It's very disruptive. And I see a lot of that. It's very disruptive, and I know it's hard for caregivers and kids. Sometimes want to rotate the responsibility. It's very hard. The bathroom is here, and now they get moved, and they're like, where's the bathroom? And now mom's incontinent. It's because she can't find the bathroom. So that's really important, structure and regular activities. Sleep and eating, and what I do is educate caregivers. These seem so silly to teach this stuff, but it's so face-to-face. I try as much as I can to sit at the bedside, particularly in the office, but even in the hospital. Sit at the bedside and speak to the person face to face. They can't hear you if you're behind them, next to them, above them, whatever. Using verbal cues. A lot of people that are hearing impaired definitely read lips. Slow and deliberately, never surprise. Jump up on somebody and you may get hit in the face or something. And you really, I actually, sometimes I know, because I could hear a lot of stuff, hustle and bustle going on, you have to be the calming force to come in and to control the situation as best you can. And as caregivers, you know how difficult that may be when people are agitated or combative or whatever, but not to argue with the dementia, because you'll never win, as you know, right? Humor and laughter. And we talked about who was that person before, use that information to individualize, care for them. Personal interaction based on cognitive level, including things, recreation. And I see this sadly too, is that families are still giving their parent, like the New York Times or the Wall Street Journal. It's frustrating. They can't understand it. So you have to bring down their recreation to their cognitive level. It's not, you're not being, you're not trying to embarrass them. It's frustrating for an individual. Somebody that may actually have been an avid knitter, maybe now they use the yarn and whatever. So that type of activities you really need to suit to the individual, to their cognitive level. It makes it more enjoyable for everybody. Distraction or redirection, that's a good one. Walk away if you need to. Some of my caregivers say that they actually will leave and come back in. I used to have husband and wife couple. He said she would say to him, "Who are you? I don't know who you. Get out of here!" And he would leave, go around the block, and come back, and she would recognize him again. Everyone's different. You have to be really creative. Flexibility and go with the individual's pace. Now, I love this. It looks kind of foreign and weird, but you probably do this yourselves and don't even realize it. And caregivers and facilities do. It's called activities of daily living desensitization. So bathing is one of the most challenging parts of caring for an individual with dementia, I think, right? My neuropsychologist actually has a good video where he teaches caregivers before and after. You start with a hand. Wash a hand, wash the other hand. Then you go to an arm. So the least noxious, area, the least threatening area. Keep the patient comfortable, quiet environment, nice and warm. Then you go to the foot, then a leg, back. The last thing you do is go here. So usually when you get around here, a person knows what you're doing. You're just helping them bathe. You have to, suit that to everybody. If the individual doesn't want to get fully undressed, I have patients that really will not get into the water. So you have to work around that. But this really works. So it may take a little more time at first, but once you get into the, routine of it with an individual, it really works, and then it goes much faster. People aren't screaming and biting and pinching and whatever. In the hospital, people that need complete assistance with their ADLs, what do they first do? They change their diapers. They're in a strange environment, and some stranger's coming at me and taking my pants off. What do you think I'm going to do? I'm going to beat them back too, right? So you really need to use this in all care environments. Some people have other techniques, and they're always interesting and fun to listen to. So always remember, anticipate the challenges and difficulties, and they are the norm. So what is palliative care? In palliative care, I think sadly this country had to give it a name, and not only a name, but like had to give a certain certification. They had to be trained in palliative care. I mean, palliative care is what healthcare providers should do every day. It's basically focused comfort care for people with advanced and potentially life-limiting illness. I do palliative care every day. Even though I'm boarded in it, I should do it every day. It's not hospice care. Hospice is a specific determination. Hospice and palliative includes all of these areas. Palliative can be curative, so people that have, say, a kid with cystic fibrosis has a lot of symptoms, but you're going to treat that individual. They're not going to be on hospice at that point. That's just an example, and it's a continuum of care where eventually, the individual may qualify for hospice, which is actually a program of care. These are the distinguished things. Chronic illness can seek life prolonging, so people with a malignancy they can have for decades, but may have a lot of symptoms that need management, shortness of breath, pain, etc. That's palliative care. And hospice is really for someone that has a prognosis of less than 6 months if the disease progresses along its natural course. Basically, they have to have a terminal illness. And the way that they pay for it is different. Hospice is, nobody pays for palliative care. That's basically it. It's true. It's bundled into the usual doctor's visit care. Nobody pays for that long family visit, that informational session, discussion of goals of care. No one pays the doctor for that. Well, you get a little bit of payment now since the Affordable Care Act, but anyway, that's the difference between hospice. We talked about that. Most hospice is provided in the home, nursing home. Most hospice is not provided in an inpatient hospice facility. It's provided in what the person calls their home. Cancer is still number one, but other life-limiting illnesses, including, you could see Parkinson's, Alzheimer's, a lot of people actually jump on board for hospice there too. You have to be very advanced and actually to qualify with a dementia diagnosis. I don't know if I have that slide. Very advanced. You have to basically be almost not able to nourish yourself by mouth, have to be dependent on all your activities of daily living. You have to be almost like a fast, it's a dementia scale, end stage, very end stage. Is she still eating? Probably not. Yeah. That's changed. So when I used to be a hospice medical director, we used to have people on for debility or failure to thrive. Like, for example, I have a lady who's 100 in my practice. She's very frail. She doesn't walk anymore. She's got this terrible osteoporosis. Her chin is down in her tummy. She's still eating, and she's in a lot of pain and a lot of discomfort. She does not qualify for hospice. Right. So we used to be able to bundle, the patient's just got a failure to thrive, no more. So it's hard often to bring hospice in, so you try to palliate symptoms, and when the person transitions to more end-of-life care, then we bring hospice in. For dementia, it's very hard to qualify people. This is the team. The medical director is somebody that's hired by hospice to assist with oversight of care, but the attending physician can remain your doctor. A lot of people don't know that. Oh, do I need to use the hospice doctor? No, you don't. You can use your own primary care physician and your specialist. You can continue to go to for hospice and continue to get the hospice team and see your doctors too. Hospice nurse, hospice aide, volunteers, huge volunteerism, spiritual, pastoral, social worker, and you can continue to get things like physical therapy and occupational therapy. You can continue treatment for your other conditions. Hospice may not pay for it. If you want to treat your heart disease and you're on it for lung cancer, they probably won't pay for your metoprolol. But you can continue to get the care that you need, but the focus is on keeping people home and comfortable. This is the criteria for hospice eligibility for dementia, not just Alzheimer's, dependent on all ADLs, incontinent, and basically mute, and then have had any of these here, as pneumonia, some serious infection, bed sores. So, yeah, you have to be really, almost, which is sad, because it's so wonderful when hospice comes in. But yet, and what happens is I'll bring hospice in, and then someone will do so well because all the support in there, and they take them off. Which I say to the family, that's a good thing. And they're like, no, it's really not. They took my hospital bed. They took my oxygen out, right? Anyway. This is a great poem. It's small, so I'll read it to you. This is the ending. I understand how difficult it must be for you to watch me become less of the person you once knew. My body is here, but my mind is not. The things we once shared, I may have forgot. This will be our longest goodbye, for the mind of the person you love is slowing and will die. I will not act or behave like the person I once was, but please remember, it's not something I have control of. I'm sorry for this burden I put on you. There will be some rough days with teary eyes and hearts of blue, but let the love of so many years carry us the rest of the way, because this is not forever and our souls will meet again one day. Thank you. He died of Alzheimer's. I'll take questions if you... Yeah. Yeah, so vitamin B12 deficiency actually is associated with cognitive impairment. Not necessarily Alzheimer's per se, but it is definitely a vitamin that's necessary for normal brain function, including depression, anxiety. So I always check B12 levels. Yeah, so there's a lot of there's so many different of the symptoms that are challenging, including eating, sleeping, continence. So that's a tough one. And so what you need to do the best you can is try to keep the person, try to get them back into a set where they will sleep at night and be awake during the day. And it's challenging because you're going to have caregivers that are stimulating them. They may need a little nap. I mean, their brains actually are working very hard to fight the disease. So people do need more sleep. So they may need a little downtime at the end of the day, because everyone talks about that sundowners thing, which is actually kind of a delirium associated with dementia. People are tired. So they may need a little downtime, a little rest, and then they'll sleep better at night, but not like a 4-hour rest. Right, so it's challenging, and I work with families to try to push the bedtime a little bit later, because the other thing is getting people in bed at 6 p.m. I said, what time? Oh, they're up at 3. Oh, what time they go to 6 o'clock? Well, they've already had 9 hours of sleep, right? So that's challenging. And sometimes we have to use medications. Melatonin actually works for some people. Using melatonin to try to elevate that chemical tells your body and your brain when it's time to shut down. So giving melatonin may be useful. But it takes time and effort, and everyone is a little bit different. So sometimes I do use medication, though, to help people sleep better.
No Tylenol PM.
No PM. Diphenhydramine is like the number one. It's like the anti-brain. That's Benadryl. You really don't want to use Benadryl. Don't use Benadryl. Herbal supplements, great. In fact, there's a really... a big study. The delirium guru in geriatrics is a woman named Sharon Anui, and she has a whole protocol for hospitalized patients. Soft music, non-pharmacologic sleepers like chamomile tea, soft light, sometimes a nice bath before bed, things like that. Lights down, no stimulation, no screen time. TV for everyone that wants to sleep. TV and computers and stuff and cell phones are very stimulating to the brain. So you need to shut that stuff off. And it may be easy to put somebody in front of a TV, because it keeps them quiet, but that's not really good fodder for healthy brain sleep. So that's challenging. You have to be very creative with a lot of this stuff. And it's not like one size fits all. So I think that that's their reality, and I think that if you try to correct them, then it probably will get them agitated. So you have to also pick and choose. You have to pick your battles, right? So if that statement doesn't cause disruption to anybody, then you let it go. And because someone will say also, my mother's coming home. Where's my mother? Where's my mother? And someone will say, Mom, your mother died 20 years ago. That may not be the right thing. And you have to individualize. But correcting somebody when that's their reality base is usually wrong. Now, if it's going to cause harm, you need to intervene, right? If somebody's doing something that they run into traffic or do something that's dangerous, then you have to correct them. But you have to pick what's important to correct. If it's not going to impact on them in a negative way or disrupt the household, then you shouldn't address it. You distract. Talk about something else. It takes a lot of savvy and creativity to deal with this kind of stuff. Any other questions? Depends on the extent of the dementia. It depends on the patient's personality. Most of the time, you're not really going to be successful in changing that behavior completely. But you could probably change the behavior to adapt to do something in a more appropriate place or time. You know what I'm saying? Like I had a patient who, she's actually very impaired now, but her daughter would take her out in the car and she'd try to get out of a moving vehicle. So we tried to identify time of day, like what was driving her to try to get out, and see if actually we could maybe change the time of day when she took her out to the market, or things like that. And in a care environment like this, you have to. It's not one size fits all. But I guess the answer would be that if it's a dangerous behavior, then you need to correct it and try to redirect it or even medicate it. If it's not dangerous, then you got to let it go sometimes. Somebody that asked the same question over and over and over, and it's like, Mom, you just asked that, you just asked that, you just asked that. It's like, it just feeds the anxiety and agitation, and that may need to be managed, the anxiety. There may be anxiety under there that needs medication to manage the anxiety. So it's not one size fits all. And all of this, there's tons of good information. The Alzheimer's Association has lots of good stuff on their website, how to be specific. And there are great books out there for caregivers, specific issues, hygiene, eating, brushing your teeth, getting somebody to sleep at night, all those there's books on this that are specifically written for caregivers. I have a bunch of them that I always recommend to my patients. Yeah. It depends on the individual. I think sometimes people develop the sensation is uncomfortable, so whether it's cold or an unfamiliar, I think some of it may be that the task itself is very complicated. And so it just seems so overwhelmingly confusing. So that's what I mean, if you do a little at a time, then you often can get to the bath or the shower. But you have to be patient. So if you say to somebody, okay, come on, Mom, let's take a shower, let's take your dress off, and I'm going to run your bath. All that information is like the first 2 words they hear. The rest is just a garbled mess, and it just is so confusing that they just say no. So it could be anything from like a sensory type thing that's uncomfortable to that is just the task is so overwhelming and that it agitates the person. It's a hard one.
Yeah, but it's the water. It's the water that...
It is the water with some people. So that's where you put an individual partially clothed on a shower chair in the shower and use a handheld and start with the hand and the feet. That type of thing where after you do that enough, maybe you could work up to partially unclothed. And you know what I mean? And some people you never get there. Some people have a sink shower and they never ever get there, and they have good caregivers that wash them up completely, will never get in there. So you have to be very creative and very patient.
Thank you so much.
Thank you, everybody.